8:30. I want to welcome everybody to our Healthy Living series. The first class of this Healthy Living series is Keeping Your Knees Healthy. And this is presented by Brandon Taylor. And I'm going to turn it over to Brandon, and I will let him tell you his credentials. I did want to let you know also that we are recording this presentation. It will be on our YouTube channel for you to view later and for you to share with others. And also we will have a question and answer period at the end. If you want to just type your questions in the chat box, we will ask Brandon your questions and get the answers. So I'm going to turn it over to Brandon now, and thank you for presenting.
All right, hello everyone. I appreciate you all joining us, this afternoon. Just a little bit about myself. I'm a physical therapist at North Kansas City Hospital. I predominantly do outpatient care. And when asked to do this presentation, I really wasn't sure what kind of angle to take with it. What I wanted to kind of strive for was just to provide some basic information in regards to helping to keep our knees healthy and to, helping to reduce our likelihood of developing symptomatic pain as we get older. So what I'd like to discuss today to get started with is really what this is centered around is osteoarthritis, or OA of the knee. So let's start with kind of just some risk factors. I don't know if everybody has this handout that I made to kind of discuss the template of the presentation. But with symptomatic OA, so pain in your knees due to osteoarthritis, the likelihood of developing that as we get older, 60 years of age or older, is 18% in women and 9.6% in men. Now, with some of the research that I was doing, there's a few things that can predispose us to developing symptomatic OA. Now, nothing is black and white. It's never like, I have this, therefore I'm going to have knee pain. But these are risk factors that we have some say over. So the first one is obesity, or body weight. And I'll go into more detail with these as we go through. The second would be a prior knee injury or prior knee trauma. Increasing age. We tend to develop more arthritis as we get older. It's just a byproduct of aging. The female gender, we have less control over that. And activity and occupational risks, which we do have some say over. So the first thing I'd like to discuss would just be obesity. And with that, almost 25% of cases of knee pain can be attributed to being overweight or obese. So it is from my perspective, the biggest risk factor that we have for developing symptomatic knee OA. And the reason for that is the amount of stress placed on our knees when we are active. When we are walking, there are 2 to 3 times our body weight of force on our knee joint. When we're climbing stairs, it's 3 times, and when we're jogging or running, it's 4 times our body weight. And so the way that I try to relate this to patients are, let's imagine we're going to climb a flight of stairs. If I'm 10 pounds overweight, that's an extra 30 pounds of force on my knees every time I climb a stair. If I'm 100 pounds overweight, that's an extra 300 pounds of force on my knees. So it's a multiple factor as far as the amount of stress on our joints. And what the research has done is that has shown that reducing our body weight by 10% or more has been shown to reduce our likelihood of experiencing knee pain and symptomatic OA. And we'll go into more of this in more detail later. The next thing would be having a prior injury to your knee. What we know is that with pre-existing injuries, it increases the likelihood of us experiencing knee pain and osteoarthritis later on in life. So as for an example, a cruciate ligament injury. So if anybody's familiar, like an ACL tear, that would be that's your anterior cruciate ligament, or your PCL, which is your posterior cruciate ligament. Those are cruciate ligament injuries. And that increases your likelihood of developing symptomatic knee OA by almost 20%. And oddly enough, signs of that osteoarthritis can show up on an X-ray within a couple of years of the initial injury, so it can happen quite quickly. With meniscus tears, it's a little over 10%, and with a tibial plateau fracture, it's about 13%. And a tibial plateau fracture is a fracture of your lower leg bone up close to the knee joint, or actually up into the knee joint. And any kind of injury that disrupts the joint itself tends to lead to more osteoarthritis later on. The next risk factor would be increasing age. Now, this is something we don't have control over. So as we get older, we tend to, our body's capacity to manage inflammatory processes in our joint tends to change. So our body tends to try to maintain what's called homeostasis, or a balance between function and inflammation in our joints, where our activities can create an inflammatory condition and can cause our joints to start to wear prematurely. Our body produces products in our joint, namely synovial fluid and compounds in synovial fluid, such as hyaluronic acid, that function as anti-inflammatory compounds, which help to mitigate some of the effects of the activity. As we get older, our body's ability to maintain homeostasis or decrease the natural inflammation that occurs with activity can diminish, and that can create an environment where inflammation and osteoarthritis tends to foster more. With that, the incidence of OA tends to be greatest between people that are going into middle-aged and into later age. So 50 to 75 tends to be when we're going to be more likely to develop that. But oddly enough, as we get even older than that, if you've made it to 80 and you're doing okay, odds are you're probably going to continue to do okay. It tends to plateau at that point. The next risk factor that we discussed was female gender. Once again, this is a risk factor that we don't really have any control over, and there's a few reasons why this occurs in females more than males. The first being that men can have a greater volume of articular cartilage at the kneecap and at the top of the tibia. And think of your articular cartilage as like a cushion. And with a bigger cushion, there tends to be a less likelihood to develop an osteoarthritis. The other risk factor would be that women tend to have greater forces on their knee joint, and they tend to have larger valgus knee movements with things that require them to jump or move quickly. A valgus knee movement would be, imagine you went to jump, and as you landed from your jump, your knee kind of jutted inwards. That is a valgus stress on the knee. And that increases our likelihood of developing medial collateral ligament injuries and anterior cruciate ligament injuries, as well as medial meniscus injuries. So the reason for that with females is women tend to have a larger Q angles, which are, for lack of a better description, wider hips. And that tends to place the knees into more of an inwards position anyway, which increases the likelihood of knee injuries. So that could contribute to more stress on certain parts of the joint, as well as an increased likelihood of developing a knee injury from activities and from sports, which would in effect increase likelihoods of developing knee OA. And then the final thing that I mentioned earlier on for risk factor would be occupational risk. With activity, sometimes activity is not a bad thing for our joints. Our bodies are very adaptive. So with some of the research that I was doing, for instance, a heavy physical workload may not contribute to knee OA, meaning it may be a non-significant risk factor. And part of the reason for that is load over time, permitting that it's not a really stressful load, or it's not done abruptly, where we go from very little activity to high levels of very physical activity very quickly. Give your body time to mount a healing response and a response to the stress to make the joint stronger. And so, for instance, there's some newer studies that demonstrate that people who do short distance running, so we're talking, 3 to 5 miles of running several times a week, have a lower risk factor for developing knee OA than people that swim. And the thought process on this is that compressive load of jogging loads the articular cartilage, and over time, the cartilage becomes stronger due to that repetitive stress. And because of that, it becomes more wear resistant, and people are less prone to developing knee OA. Now, that is not true in people with pre-existing injuries. So if you've injured your knee, activities that increase the load on the knee tend to cause more deterioration to the knee joint itself. With physical activities, the thing that was shown to have the biggest risk factor for developing knee OA was kneeling. So jobs such as laying carpet or hardwood floors, or carpentry, things like that, where you're on your knees a lot, or even gardening. Those are things that might be best to kind of minimize as much as possible, or wear protective knee pads when you're doing those types of activities, because we obviously want to do what makes us happy. So with the physical activity component, like what I was touching on earlier with the jogging, higher levels of intense physical activity can cause development of knee OA. And for instance, running can be a good thing for us, but running 20 or more miles per week has been shown to develop or contribute to knee osteoarthritis. Years ago, I was taking a course, and they were talking about the effects of long distance running on our articular cartilage. And one thing that kind of stuck out to me is that they were doing an MRI study on marathon participants. And after running a marathon, the MRIs of the knee showed softening of the articular cartilage of the knee for upwards of 2 months following the bout of running. So kind of the take-home message is activity is a good thing, but too much activity, just like too many cupcakes is a bad thing, too much activity can also be a bad thing as well. So just like with anything else in life, it's all a matter of striving for balance. All right, so now that we've discussed kind of the risk factors of knee osteoarthritis, we can kind of talk about treatments. Some of this is going to be from a physical therapist standpoint, and some of this is going to be from the standpoint of discussing the risk factors that we've talked about already. So the National Strategy of Osteoarthritis and the CDC Arthritis Foundation provided these strategies for reducing the likelihood of having symptomatic knee OA, and those were self-management, exercise therapy, injury prevention, and weight management. So a lot of the same points that we've discussed earlier. And so with exercise therapy, to be very frank, there has not really been a lot of research that's shown one variety of exercise is superior to another. So when I'm working with patients, the biggest thing is the exercise comfortable? Does it cause you to have pain? If it doesn't, then that's probably good exercise for you. Aquatic exercise can be very effective for people that already have symptomatic OA, and it's been shown to be equally as effective as land therapy. So what we want to focus on when we're addressing the knee specifically is exercises to strengthen the muscles around the knee joint, exercises that require some degree of weight training and weight bearing, because that can help strengthen our muscles and strengthen our joints as well, and things that help restore or maintain normal mobility to the knee joint. So when we are looking at risk factors for developing knee OA, the things that kind of really stand out would be weakness in your quadriceps muscle. That's the muscle on the front of your thigh. Weakness in your quadriceps tends to cause more joint reactive forces or more stress on your joint with weight-bearing activities. So anything that would help to strengthen that would be a good thing. And there's ways to do that through weight-bearing, and there's ways to do that through non-weight-bearing. So weight-bearing examples would be squats, wall sits, practicing standing and sitting from a chair. Now, if somebody already has symptomatic or a painful knee, that type of activity might be too aggressive to start with. Something such as straight leg raises or long arc quads, or just tightening your thigh muscle may be a safer avenue to start, or doing aquatic therapy might be a safer avenue to start with that. And then the other risk factor for having symptomatic knee pain, as far as a physical capacity, would be having a lack of mobility in the knee joint. And this is more noticeable when there's a loss of the ability to extend or straighten your knee. And the reason for this is this causes more wear on certain aspects of the knee, namely the patellofemoral joint or the back of your kneecap. And it also helps, it decreases the ability of your joint to kind of load the joint evenly. So you get more stress on certain aspects of the joint for a longer period of time when you're active. And so maintaining the ability to be able to flatten and straighten your knees is very important. So doing stretches that stretch out your hamstrings, the back of your thigh, and doing stretches that stretch out your ankle joint and your calf are really effective for that. So calf stretches. And those can be done seated, or those can be done in standing as well. And if people need examples of that or need additional handouts following the presentation, I'm more than happy to provide those for people. The other big thing that we touched on at the very beginning of the presentation was weight management. To be very honest, exercise is important. Being physically active is very important. So doing cardiovascular exercise, getting your heart rate up, and doing things that require cyclical motions of the knee, so riding a bike, walking, those are all great things you can do to help reduce your likelihood of developing knee pain. And the other big linchpin in this is weight management, because really that is the biggest risk factor for developing knee OA. So for instance, for each 11 pounds of body weight or extra weight, there's a 36% increased likelihood of developing knee OA. And so that's a very, very large risk factor. And the association of having a higher BMI or higher body mass index can result in development of knee OA fairly early in life. So for example, people with elevated BMIs for men can have early onset of knee osteoarthritis as early as 20, and for females as early as 11, which is quite early. Now, obviously, there's other risk factors that play a role with that, but it just goes to show just how very much important healthy weight is in regards to managing our knee health. As well, an 11.2 pound weight loss can reduce the likelihood of us developing symptomatic knee OA in women by 50%. And like we talked earlier with weight that's placed on our knees with stair climbing and running, for every pound of weight loss, there's 4 pounds of less stress on our knees when we run and 3 pounds less force on our knees when we're climbing stairs. So it's a very, very large effect. So what's been recommended as far as managing our weight for reducing our likelihood of developing knee pain is that a 5% loss of our body weight has been shown to provide some relief from knee pain, but really more noticeable effects have been demonstrated with people losing 10% or more of their body mass, which it can be a lot for some people. But that's what the research kind of shows right now, that it has the biggest effect in regards to reducing our, people's issues with pain and symptomatic knee OA. Now, as a physical therapist, I can talk about weight management and stuff, but really, like speaking with your physician about that, or a dietitian would definitely be the best approach to take as far as managing this and trying to find a balance between calorie reduction or an increased activity to help lose that weight. So kind of rehashing with what we talked about today, the biggest things that we can do for ourselves is maintaining a healthy body weight, maintaining a degree of physical activity on a consistent basis, as well as trying to do regular physical activity and maintaining flexibility in our knee joints. So do we have any questions?
Hi, Brandon. Yeah, we did have a couple of questions. Somebody wanted to know about knee braces. They had heard it may make it worse. What
were the knee braces in regards to?
Just like
like a sleeve or like a hinged brace, or like an ACL brace, which is like a sport brace?
Like a sports brace.
Like a sports brace. I'm going to give you my opinion on it. To be honest, I haven't done any recent research on this. I just know years ago, my first several years of practice were in sports medicine, and for following ACLs, patients typically are issued like ACL braces. The research is not overly promising in regards to the effectiveness of the brace as far as reducing your likelihood of developing another knee injury if you're using it for injury prevention. As far as any negative effects of wearing the brace, as far as like making your muscles weaker, I really wouldn't worry about that too much. I mean, if you're overly reliant on the brace, and you're losing some of that proprioceptive or balance feedback because the brace is doing a lot of the work, you might think to yourself, okay, I'm using this brace a lot. Maybe I need to do some additional exercise to help counteract the effect of that brace as far as reducing my proprioception on my joint. But as far as like a direct negative for wearing the brace, that I don't think that would negatively harm your joint. So I wouldn't worry about it too much, but it might be an indicator that you need to do some additional exercise.
Okay, thank you. Another question was, they said, after I exercise, I have a lot of pain. What do you suggest, heat or cold, to manage pain?
It's really in the eye of the beholder with this. Ice is an analgesic as well as an anti-inflammatory. So I would say if you're having pain after exercise, probably ice is your safer bet. But osteoarthritis in our knee is a balancing act. It's a balancing between maintaining a non-inflammatory environment and maintaining an inflammatory environment. So activity in general creates inflammation because it causes stress on our joints. And so inflammation is normal. It's part of a healing response, but we don't want to create so much inflammation that we cause residual pain after the activity. So I would probably put some ice on it, but you might also rethink of what you're doing for activity and try to find a better balance where you're not having soreness afterwards.
Okay. There is one more question. It said you had mentioned weight bearing was good exercise for the knee. Is swimming as good?
Swimming's wonderful. I mean, really, like the point I was just trying to make was we need to exercise, but we want to make sure that this is comfortable. Weight bearing helps increase the density and the thickness of your articular cartilage. So just like how earlier I was mentioning that some of the research is showing that people that do short distance running have less of a likelihood of developing knee OA. The reason for that is the compressive load of jogging strengthens your articular cartilage. So weight bearing is important because it helps with our bone health and our bone density, but it also helps with the density and the wear resistance of our articular cartilage. So weight bearing can be done in the pool. So the deeper the water you're in, the less weight bearing there is. The more shallow the water is, the more weight bearing there is. So yeah, the pool would be wonderful for that. Swimming itself, that's not really a lot of weight bearing, but it can be beneficial for strengthening your quads, which can be another helpful thing.
Okay. I didn't have any other questions, but I did have a comment. One of the participants wanted to thank you for the presentation.
Thank you.
Okay. If there's no other questions, I guess that will be all. And Brandon, I want to thank you again for the presentation. It was great information. So
Thank you everybody for attending.
okay, bye now.
Bye.